This case today is going to be on septic shock. So the patient is John Smith, a 67-year-old male. He presents to the emergency department with altered mental status, fever, hypotension, and tachycardia. He has a recent admission from a week prior noted in his chart from a UTI in which he was discharged home on oral antibiotics. The patient appears to be a poor historian, unable to answer questions. His wife, however, reports that over the past 24 hours he has become warm and flushed, with a fever as well as chills. She reports he's normally only forgetful, but has become increasingly confused, anxious, and restless. She also reports that when she checked his blood pressure using their at-home device, it was low, but his heart rate was high. She states he was recently treated for a UTI, but over the past 24 hours has had a decrease in urine output, only voiding once in 24 hours. The patient has a history of type 2 diabetes, chronic kidney disease stage 3, and hypertension, as well as a recent diagnosis of that UTI 1 week prior in which he was prescribed oral antibiotics. Upon physical examination, the patient's blood pressure is 85/50. His heart rate is 120 beats per minute. His respiratory rate is 24 breaths per minute. His temperature is measuring at 101.8 degrees Fahrenheit, and his oxygen is 92% on room air. His skin appears warm and flushed, and his pulses feel bounding. Crackles can be heard in his bilateral lungs. Neurologically, he is alert to self only. Based on his clinical presentation and symptoms, the most likely diagnosis is septic shock secondary to urosepsis. Now, septic shock is a life-threatening condition caused by systemic inflammatory response to infection that leads to severe hypotension, tissue hypoperfusion, despite adequate fluid resuscitation. The patient's low blood pressure, tachycardia, fever, altered mental status, and decreased urine output are all hallmark signs of septic shock. His recent history of a UTI suggests the urinary tract as the likely source of infection, which has progressed to systemic involvement. Septic shock is characterized by dysregulated immune response to infection, which leads to widespread vasodilation, increased vascular permeability, and multi-organ dysfunction. The presence of acute kidney injury, the decreased urine output, and altered neurological function further supports this diagnosis, as these findings indicate that multiple organs are starting to dysfunction. Several diagnostic tests should be ordered to confirm the diagnosis and assess the severity of it. A CBC is needed to identify leukocytosis or leukopenia, which could both indicate an infection. A lactate level should also be obtained, as a lactate over 2 suggests tissue hypoperfusion and anaerobic metabolism, which are both common in septic shock. Blood culture should be collected to identify the causative pathogen. A urinalysis and urine culture are necessary to confirm that the urinary tract is the primary source of the infection. Additionally, a comprehensive metabolic panel is needed to assess the kidney and liver function. An ABG can be ordered to further evaluate metabolic acidosis due to the lactic acidosis and the severity. The management of septic shock requires rapid and aggressive treatment to prevent further deterioration and reduce the mortality. The first step is to treat early with fluid resuscitation, such as intravenous crystalloids, within the first hour to try to restore circulatory volume and improve tissue perfusion. Broad-spectrum IV antibiotics are also initiated immediately, with antibiotics such as Zosyn or Vanco that are used empirically until cultures are available. If the patient's blood pressure remains low despite the fluid resuscitation, vasopressors such as norepinephrine can be administered to maintain a MAP of 65. In cases of respiratory distress or worsening hypoxia, oxygen or even sometimes mechanical ventilation may be needed. Additionally, source control is critical. So that means if the patient's in the hospital, perhaps removing infected catheters, draining abscesses, or treating the underlying infection appropriately.